participants.
Hope the conference is going great.
Yeah. We are all ready, sir.
Yes, sir. Can you hear me?
We can hear you, but it's not very loud.
Yeah, just a minute, it's connecting.
Can you speak again?
Yeah, he's connecting, sir. Audiovisual guy is connecting in a minute.
Okay, okay.
एक्सटर्नल दिखाना एक बार मेरे को एक्सटर्नल लगा दे एक्सटर्नल लगा रहा हूँ आगे Hello.
Hello.
Yes,
Yes.
sir. Am I audible, sir?
Yes, you are audible.
So good morning, everybody.
Good morning. You are audible and visible as well.
Oh, thank you. So I hope the conference is going great in Islamabad.
It's really going great. We have an excellent weather here and excellent atmosphere with excellent participants.
Oh, really great. So we are all set for today's demonstration. So before we start, anybody has any question or something for the yesterday's presentation demonstration?
Yes, we do have a question from Professor Ajmal.
Yes, please.
Satish, I just want to know, you once tried to tell us a trick about the collator wand, that you removed some pin from it so that it doesn't choke during suction.
Yes. So what happens?
If you can
The,
tell us.
the suction port of the cobbletter vent, is divided into two parts by a titanium chip, which is practically of no use and unnecessarily narrowing the suction channel. So, when you, remove the tissue, once you particularly ablate, as the tissue goes in, it clogs the suction channel. And, repeated clogging is something which is, not good for the temperament of the surgeon, as well as for the surgical process, as it violates the fields. So what we do, we remove the the titanium chip between the two suction ports. The suction port is divided into two by a thin titanium chip that is only on the surface, not in the depth.
Okay.
So if you remove by a wire cutter, your suction port really becomes big and it rarely clogs. Yesterday you saw in the entire case, not even once the suction port was clogged.
Yeah. We
So
noted. Thank you.
So that is really useful, sometimes, particularly in extensive cases where you need a high power suction and you don't want repeated clogging and all that.
Dr. Jain, we have another question. I was meaning to ask that we do understand that the JNA does take branches in a stage 3, stage 4 from the branches of the internal carotid artery as well, more specifically from the Vidian. But as we could see yesterday that the carotid was somewhat dehiscent, and whilst you were removing it, have you ever had an incident where there was a direct branching or angiogenesis from the cavernous ICA to the JNA. Have you ever had that incidence? Because in
Yes.
that regard, it would be difficult to just tweeze out the JNA without a major bleed. I was just wondering about it yesterday.
Yes, yes. We have seen couple of times, and it's a regular feature once JNA invades, to the skull base, particularly to the cavernous sinus and the paracavernous region. Once it invades the temporal lobe, particularly intradural, it acquires vascularity from the middle cerebral branches as well. So there are two sorts of internal carotid supplies. One in the nasopharynx, at the sphenoid level. The median artery also is a branch many a times from the internal carotid, sometimes from the external internal maxillary as well. So once there are extracranial branches, if there is an extracranial branch, what you can't do anything, you can't embolize it. What you need to do is you should be able to deal with that bleeding. You can anticipate some extra bleeding, you can arrange some extra blood. You have to prepare to deal with extra bleeding. That's the only thing, the importance is. Once it is an intradural branch coming from any of the branches like middle cerebral or whatever, the significance is you have to have open approach to prevent that vessel, retracted into the brain and keep on bleeding. That's a different scenario. The safety caution is very, very important in that situation. And then you have to have an open approach to catch that vessel, coagulate with that vessel, and deal with that vessel.
Thank
So
you.
these are two different scenarios of internal carotid vascularity.
Thank you, Doctor.
But in any given situation, you can't embolize. You should not embolize the internal carotid circulation branches.
Thank you.
Any more question, or do we go ahead with today's proceeding?
Sir, I think we should go ahead and we will ask if there are any.
Yes, yes, yes. So the first case today, can you connect the laptop? Let me know when you get a CT scanner on screen. Are you getting any CT on the screen?
Yes, there is CT on, we can see the CT.
Yeah. So this patient had bilateral polyposis. She was operated somewhere earlier. That's a revision situation. And what we see, the CT is very important to know the extent of disease as well as the reason for the so-called recurrence and how to deal with it. See, once you deal with the eosinophilic sinusitis, eosinophilic disease, now the CRS has been, more and more classified into various endotypes. And each endotype has a different underlying pathophysiology. And understanding that fact has really improved the overall outcome of sinus surgery. And this disease is basically divided into two groups as phenotypes like polypoidal and non-polypoidal sinus disease. And non-polypoidal is not that virulent, mostly neutrophilic driven. Infection is one of the hallmark there. And the other one, the eosinophilic, which is mostly presenting as a polypoidal, that is more virulent, that is more resistant, recalcitrant disease, and chances of so-called recurrence are high if not treated the underlying cause. So to understand the underlying cause, various pathophysiologic mechanisms have been identified and different endotypes have been described. Like AFRS is a different endotype, allergic fungal rhinosinusitis. AERD is a different endotype, respiratory, aspirin exaggerated respiratory disease. The cystic fibrosis is a different endotype. Eosinophilic sinusitis is a different endotype because the underlying pathophysiological mechanism is altogether different. And to understand and treat that mechanism is the main hallmark of treatment rather than relying for a cure on surgery. So now that, the goal of sinus surgery has been redefined. The goal of sinus surgery has been redefined in the sense, earlier, when Massel, Klinger, and Stamberger defined the role of sinus surgery, was just to open up the sinuses to establish ventilation and drainage. it works very well, and it has been, still it is a goal of the sinus surgery. But that is not everything. In the past, that was taken up. What Messerkinger and Stamberger did was widely accepted, and people went in doing, worldwide sinus surgeries everywhere. And they got good results, but after a period of time, majority of the patients face the recurrences. And that so-called recurrences, made the researchers work into the region what this kind of disease is, what actually the disease is at the molecular level, and then more and more work at a research level has been done in past 3 decades to understand this disease more and more, and a lot of things have come out. So now the goal of surgery has been redefined, as this has been defined as a immune modulation disease, inflammatory disease. This is not infection. This is inflammatory disease, mostly eosinophilic driven disease with a lot of endotypes with different underlying pathophysiologic mechanisms. So now the goal has been redefined, and most, on the entire cascade of, sinusitis development, the only weapon we have now in the present era which works is the steroid. So steroid is the mainstay of treatment in most of these, polypoidal sinusitis, the recalcitrant disease. But we all know in our hearts and hearts, we can't give steroid to our patient for long run. How long we can give steroid? They have their own adverse effects. So now the strategy has changed. The role of surgery has been redefined to different goals. Number one, obviously to establish the ventilation and drainage, open up all sinuses to establish the natural ventilation and drainage. Number two, to remove the inflammatory load. The polyp is an inflammatory load. That is the eosinophilic load. You need to remove that inflammatory load so that your topical treatment, the next goal is to introduce the topical steroids inside the sinuses, deep inside the sinuses, the area where the steroids are needed. Rather than giving oral steroids, the topical steroid can work yet without systemic side effects. That's the third goal. So now the goal of surgery is to ensure that steroid reaches everywhere. This is one of the main goals. So patient, you can train your patient post-operatively that how to introduce the steroids in the sinuses to make sure it reaches everywhere to all sinuses. That is one of the main goals. Otherwise, the inflammatory disease can come back. You have to give oral steroids. The oral steroids have their own limitations. So the entire thing relies on the ability of the topical steroids to penetrate inside post-operatively, and the success of the surgery totally relies upon that. So now the counseling to the patient is not like once we operate, you'll be all right. You have to make them feel that the surgery is the beginning of the treatment, which allows the further treatment with the topical steroid to prevent recurrences. This should be very clear to the treating surgeon as well as the patient, every patient. Now, once it comes to surgical work, that's what I'm going to share with you. And today's course is an interesting one. You must have seen as you said on videos, you have seen lots of primary sinus surgery. So this is a revision sinus surgery. And see, what you need to order is a fine section CT scan in axial planes, and then you can reconstruct to all planes. I can reconstruct to all planes. You can change to window settings, to the bone window, soft tissue window, like this is bone window setting now. And you can see in different planes, different anatomy. I'm not going in details of the CT scan, but certain different anatomy
Dr.
is
Jain,
explored in different planes. Yes, sir.
before you move forward, I would like to ask that, like in patients of chronic sinusitis, you routinely get levels of vitamin D checked, CRP, and eosinophils level checked. Do you do the
Yes.
same in the polyps, in nasal polyps patients as well?
Yes, that's a very important question. See the workup. Let me tell you other way around. Any patient with this polyp coming to you for surgery will definitely have one question. Doctor, do I need to get this surgery done again and again? Will my disease recur? Will it be a cure with your surgery? You have so many questions thrown and you don't have any answer. Because you don't know the individual patient's disease profile, inflammatory profile. As I said, this is an inflammatory disease, steroid dependent disease most of the time, and the immune complex disease, immune mediated disease. So it has been now widely accepted that anything which improves your immune system overall will have a positive impact on the overall outcome. Anything which has a negative impact on the immune system will have a negative impact. So, in order to improve the overall immunity, you need to do certain things, you need to check certain things, because in spite of the best work done sometimes, if your immune system is not supporting, the patient may not get the desired outcomes. So, in order to improve the immune system, there are certain tests need to be done. Like, for example, the eosinophilia. Eosinophilia is the single most important determinant factor. If there is too much of mucosal eosinophilia, which is sometimes corroborating with the serum eosinophilia as well, then the chances of recalcitrant disease are more. Because eosinophil disease is more and more resistant disease and it requires more and more high doses of steroids. So if the patient has a significant mucosal eosinophilia, you can counsel pre-op, per-op or post-op that you need more, long-term, more judicious use of steroids, more use of steroids, and more overall, post-operative treatment, regular follow-up. All these things is required more extensively as compared to the less eosinophilic patient. Similarly, like vitamin D you mentioned, is one of the important, determinant of immune regulation of the nasal immunity. So those patients having severe vitamin D deficiency, it has been studied so well, may not have a good outcome, and that is something you can easily get the test done and replenish and to improve the overall immunity. A smoker, you can tell them to quit smoking, otherwise their mucociliary function is not as good as compared to the non-smokers. Anything which improves the immunity, and it has been very widely well accepted, known fact that our gut microbioflora is the main determinant of overall human body immunity. We have more than 3-4 trillions of bacteria in our gut. The good bacteria, which maintains homeostasis in the body by means of regulating the immune system. So, in order to improve the immune system, we have to improve those good bacteria, and that you can improve by two ways. One is by adding the number of good bacteria in terms of giving probiotic. Probiotics are like bacterial strains, basically. The good bacterial strains to improve the strength of good bacteria. As you have a good number of and rich and diverse number of good bacteria, the chances of pathogenic bacteria growth is automatically reduced. Other way of improving the good bacteria is to provide substrate to the good bacteria, that is prebiotics, to improve the growth of good bacteria. So prebiotic and probiotic are essential part of the supplement in the overall management to improve the chances of the desired outcome in sinusitis, in CRS. So anything which improves your immunity, by and large, you need to look into it. If patient has any immune disorder, systemic immune disorder, ciliary disorder, will have a significant bad impact, negative impact on the overall outcome. So all these things has to be studied earlier. Otherwise, post-operatively, if you get to know and tell your patient, no, we have operated, but we have found this kind of disease, you may not have a good outcome, you may need regular repeat surgeries, the patient will find himself cheated, and that is one of the biggest reasons for the medical legal issues also. So we have to be, very, very, extensive in studying the patient before we take up for surgery to know the inflammatory profile of the patient so you can counsel them properly. Got my point?
Very much.
That's why the investigation profile is important to counsel them.
Okay, sir.
Now, coming to in brief, the radiological aspect of this, that's a recurrence. Let me show you on first The coronal is easier to understand by everybody. Coming from anterior to the posterior. Can you see on screen?
Yes, we can see.
This is see this 0.4 mm scan. Every movement I am going is going to be changed by 0.4 mm. Got my point?
Yes.
Every step will move by 0.4 mm, and that is something important so that we don't miss any single smallest anatomy which is relevant and important for us. So fine section CT scan is important, and what you need to order, this is important. Sometimes the patient brings us a printout that to us doesn't carry any value. What you order in a digital format, DICOM format, they will shoot in the axial section, and with your software you can reconstruct on your own in all three planes to see the three-dimensional, dynamic anatomy. So CT scan is ordered to see the anatomy as well as the extent of disease, to rule out any other pathology, and to plan the surgical approach. Now see, we have two frontal sinuses. You can see I am going behind now, that is the beak. That is the beak. So anterior to posterior I am going, and the floor is formed by the beak. See, the floor of the sinus is formed by the beak. This sinus drains from behind. So now see what is coming. Looks like three sinuses. It's not three sinuses. This is the incomplete septation which is behind, which has now come as we are going behind. See this number of incomplete septations. Now the beak has gone, and this is the frontal recess where the frontal sinus is draining from behind. If I reconstruct this part, see this. If I reconstruct and go to the same level of the frontal recess, see this. Sagittal are the cuts which are most important for the certain areas like skull base, frontal sinus. Now see, it has number of cells in the drainage pathway of the frontal sinus. Can you see?
Yes, we can see.
This is something which is obliterating the ventilation and drainage of the sinuses. And if you don't treat that, your sinuses will not be drained properly, the topicals will not reach properly, and this is a revision situation with abnormal cells at the frontal sinus drainage pathway, even the cells above the level of the beak. Can you see this?
Yes, we can see
That is
this.
the level of the beak, and these cells are above the level of the beak. That is the most difficult scenario you can think of in the frontal sinus. And these are the patients who require a more extensive approach now, since it is a revision situation. Primary situation is a different scenario. Revision, you can't take a chance for another revisions, because these are the patients who become otherwise psycho. They are fed up with the treatment, and so you have to do and think of some definitive treatment. So on the CT scan, the left side frontal sinus disease is more complex. Right side, what you can see, the opacification, it is operated, the good cavity is there, but still the frontal recess is blocked. So right side, we may not need too much of a treatment. But on the left side, because of this abnormal cellularity blocking the frontal sinus drainage pathway, and in a revision situation, it is always better to do a draft procedure to prevent the future recurrence by means of allowing the free flow of steroids post-operatively to take care of the mucosal disease. Got my point? It's not about the ventilation drainage only. The disease profile is so severe to have given this much of the disease in spite of a good surgery done is because the topical steroids are not able to penetrate deep into the sinuses because of this, lot of cells at the frontal outflow region. Can you see? It is so obvious.
Yes, we can see.
The revisions are always challenging, and we have in our mind planned a draft procedure on the left side, which I am going to demonstrate you. A draft 2 procedure on the left side. Then you see, if you go behind, let me go back. See, that's the frontal, that's the beak. As I go behind, now the beak has gone. and this is frontal recess. And as you go behind now, the cribriform plate comes into the picture. The cribriform with the medial and lateral lamella, and at the junction of this, on either side are the middle turbinate going down. That's the first vertical part. These are inferior turbinate, the maxillary sinuses, and after this treatment, patient has been given a course of antibiotic and steroids. And see, the picture must be much better than a complete whiteout what we see on CT scan. Picture is much better, endoscopic picture is much better, I believe, than the complete whiteout. And see, according to this CT scan, the patient has a complete bilateral whiteout. Can you see?
Yes, we can see.
But the cavity looks good. I will show you. This is because the CT was done earlier and then the antibiotic and a good course of steroid was given for almost 2 weeks now. So the picture is much better now, and that is much better condition to operate with less, inflammation, less mucosal bleeding, a good surgical field we are likely to get with all these means. So this is something important.
Do you prefer clarithromycin as a pre-operative antibiotic or not?
Not really. In polypoidal disease, clarithromycin has hardly any role. You have to give a broad spectrum antibiotic. Clarithromycin in sinusitis is not used as an antibiotic, as an immunomodulator in non-polypoidal sinusitis, particularly when the IgE level is low, signifying that it is mostly neutrophilic driven disease. Because the clarithromycin blocks the neutrophilic activity. Anywhere in the body, the neutrophilic infection is, the clarithromycin will work. But in polypoidal disease, which is predominantly this kind of disease, which is predominantly eosinophilic disease, clarithromycin has hardly any role.
Okay, so
yes, sir.
What is your choice in these cases?
So we give steroid mostly. Antibiotic has hardly any role. Just give 5 days of broad spectrum amoxiclav or mostly Staph aureus directed antibiotic. In polypoidal disease, Staph aureus is one of the regions which can drive the inflammation by means of its endotoxins.
Thank you, sir.
So you can see this anatomy. If you want to see the sphenoid level, this is Vidian canal. That is the V2. You see yesterday, that was the Vidian canal. That is the foramen rotundum. That's the lesser wing of the sphenoid there. Above is the depression for the optic canal. Below is the impression of the carotid artery. That is carotid artery impression. Remember you saw yesterday in the JNA case. That's the optic nerve. And that was the optico-carotid recess on the either side. If you remember yesterday, you saw in the JNA case. You remember that?
Yes, we remember, sir.
So these are the positive findings. Our case is ready, and in a couple of minutes we are going to start. So this disease, what I want to convey is an inflammatory disease. Never promise your patient that the surgery is going to be a curative one, but the yes is a step towards the cure, as it will allow after that the topical steroids to, invade deeply. And the goal of surgery, the design of surgery, the plan of surgery should be towards ensuring the topical steroids penetrating everywhere deep into the sinuses. The most challenging one, the frontals, and you have to train your patient accordingly in different positions to make sure that topical reaches everywhere.
Do you have any specific tips for that?
Specific
method, specific tip for that? How do you ensure that the steroid reaches everywhere? Because mostly we ask our patient to just bend their head forward and then use the spray.
Yes, I can tell you positions if you want. That is called a prayer position, what you said. That is a prayer position, what you said. But there are a lot of positions, what we believe. See this. This is one of the preferred position. We train our patients. Coming. Can you see this?
Yes, we can say this.
This allows the solution to go freely into the frontal sinus and olfactory region. This is one of the, and this is the what you were telling, that's a prayer position. Again, this also allows the solution to reach there, but the lying head back is more effective. And nowadays we are emphasizing more and more on this position.
Okay.
This allows the solution to reach everywhere freely.
Yes.
So penetrating the topical steroid is one of the important aspect of our surgical exercise to give to allow the steroids to penetrate deeply into the uh,
Thank you very much. That was really helpful.
sir. Then okay, so now we stick to the surgical part, and we'll in a couple of minutes we'll be back with the endoscopic picture. So anybody has any thing to discuss, any questions, suggestions, we can continue.
Good morning, sir. So the question is, sir, how you treat aspirin sensitivity, the symptom, right?
Yes, that is a very important question. And we have now almost 400 patients we are treating. That is, see, out of all the endotypes of sinusitis, let me tell you, the endotype which has the most severe inflammatory spectrum is the AERD, aspirin exaggerated respiratory disease. The reason is, in these patients who are sensitive to aspirin, normally, in the body, our arachnoid acid metabolism gives prostaglandins, which are anti-inflammatory agents, as a byproduct. The patients, and that happens by means of an enzyme cyclooxygenase. In aspirin-sensitive patient, the cyclooxygenase is, not working, and out of the arachnoid acid, the leukotrienes are formed rather than prostaglandins. That is the defect at the molecular level, which happens to occur in patients who are sensitive to aspirin. So the more and more leukotrienes are formed, which are severe inflammatory mediators in terms of involving the entire airway, not only the upper airway as well as lower airway, and present with a lot of mucosal secretion, vasodilatation, airway hypersensitivity, polyps, everything. They promote eosinophilic recruitment, maturation, survival, and it becomes like one of the most severe disease to treat. So what happens? The patient present with polyps, asthma. First of all, the diagnosis, most of the time we can clinically diagnose this patient. Most of the time, your clinical suspicion is important. Any patient with polyposis, if has a history of lower airway symptoms, you must rule out AERD first. Must rule out AERD in a patient. You can ask in their history if they are sensitive to painkillers, reaction to painkillers or something like that. If not, you can just do a skin prick test with the aspirin, and that will, diagnose the disease as aspirin sensitive disease. Now, if it is, obviously the surgery is an important goal to reduce the inflammatory load, allow the steroid to penetrate, because only thing is the steroid which can work. But the underlying pathophysiology has to be reversed to give patient a long-lasting, relief. So in that situation, you have to desensitize with the aspirin. And desensitization involves aspirin therapy. Now, if you give aspirin therapy, you cannot operate because that is an antiplatelet drug. So what we do, after surgery, after 4 to 6 weeks, when good healing has taken place, We do this aspirin sensitivity test again and desensitization in the ICU setting. And then patient is kept on aspirin for life. The moment the aspirin starts tolerating, the entire pathway is reversed now with more and more prostaglandin formed, leukotriene formation is stopped, and the entire pathophysiology is reversed at the molecular level. Hello?
Yes, we can hear you, sir.
So
Good
that is
morning,
what
sir. There is another question. What is the concentration of a steroid solution that you use? How do you make it?
okay, for post-operative irrigation.
Yes. Yes.
So it is what we use is the budesonide respules in normal saline or ringer lactate. And budesonide respules are generally used for nebulization in asthma patients. So volume बढ़ा देना और लिया दो. So we mix say initially 2 milligram of budesonide in a liter of saline, and we ask our patient to irrigate both the nostril with a rubber ball twice a day. So almost 250 ml of the aspirin is used the budesonide is used per day. Saline is used 250 ml of saline means 0.5 ml of 0.5 milligram of budesonide is used in total per day, that too topical. So that is pretty safe for the patient in long run. Then depending upon the response, the mucosal condition, as the patient has to be in close follow-up, you can reduce the concentration and frequency or increase if the need arises, something like that on the mucosal condition. Are you getting the endoscopic picture, sir?
Yes, we are getting the picture.
See the kind of polyposis. This side as well. See this? Massive inflammatory spectrum. So first of all, the preparation लगाया थोड़ी ना. Preparation involves this application of saline, adrenaline sponges, topical adrenaline soaked in Merocel. Merocel is a soft one, atraumatic to the mucosa, and it can be insinuated into narrow spaces.
So you're painting the mucosa.
Yes, just applying. You're not supposed to tightly pack it to give venous congestion. That is just simply applying. So the mucosa is decongested. That's the simple aim.
Is there any benefit of making the proper Muffet solution and then doing all this, or just adrenaline is sufficient?
Yeah, there are very ways. The simple we use just simple adrenaline. We operate all cases under general anesthesia, all nasal surgeries. And young patient, we use a pure topical without any problem.
Okay.
No. Now see this all mucosa is so edematous. That's what polyp is. So now our goal is to give wide openings so that topicals reach effectively inside. See, this is cobblestone appearing mucosa. You are not supposed to be very radical on it. See this?
Yes.
There's the maxillary sinus. In revision, you have to be careful with the anatomy can, or it is almost always distorted as compared to the primary. You never know what the previous surgeon has done. But see, there are certain landmarks which are always, safe. See this, middle meatal enterostomy itself is a landmark. See that?
Yes.
It gives you an idea of the medial wall of the orbit above. And this is the lamina papracia. See that?
Yes.
That is another landmark, you can say. See, all bony partitions have been removed during previous surgery. But mucosa is so grossly edematous. See, the entire cavity is full. This is the middle turbinate, which itself is polypoidal now. See this?
Yes, we can say this.
And there are polyps medial to it. The mucosa is polypoidal medial to it, and these are the indications for us to do a partial middle turbinate resection to allow our solution reaching more freely, more efficiently to the sinuses. In massive eosinophilic disease, that too in the revision situation, we do a partial resection of the turbinate. Not complete chopping. This middle turbinate is one of the landmarks to identify and protect the skull base, But see, in this situation, a partial resection of the middle turbinate opens up the space to ensure that your topicals reach more effectively. See the difference in the primary and revision situation. See the
Exactly.
condition of the mucosa is so bad. Can you see?
Yes, we can see. And you said that there is cobblestoning of the mucosa. Why these polyps? Because the recurrence was not very extensive. Why these polyps stopped responding to the oral steroid which you have given as a part of preoperative treatment?
Yeah, so preoperative oral steroids have not completely resulted in resolution because they have reduced, the overall inflammation much more. Otherwise, the polyps were hanging out. You see how they have regressed. You have not seen the previous condition, how
Okay.
the patient presented with polyps coming out of the nose.
Okay.
So it has given improvement, but see how long you can give oral. You cannot.
Yes. So this means that this mucosa, which has not even responded to steroid, should be removed or should be preserved?
No, the mucosa should be preserved because ultimately this is a functional surgery where the function of the mucosa, that is mucociliary clearance, is given by the mucosa only. See, I have just done a gross, gross work. I will just pack for a while. See now all sinuses in the lower part, whatever you see in the cavity, without doing much, have opened up. Just I will pack for a while and get a good field and go ahead further. See now this resection, partial resection of the middle turbinate, see now has opened up our steroid to go inside much effectively. That's why we have planned a draft procedure with a complicated frontal recess on the left side. See how turbinate is so badly affected with the disease. All mucosa everywhere is becoming polypoidal. See now the olfactory space has opened up. Can you see this?
Yes, we can say.
And this section of the lower part of the turbinate is sometimes one of the strategy in patients who present with olfactory loss to allow the steroid to reach there. The upper part of the turbinate should be preserved, may contain olfactory filaments. So the lower part certainly has to go
Okay.
to allow the steroid to reach to the olfactory cleft. This olfactory loss is of two types. One is a conductive olfactory loss, means because of the polyps, the air is not reaching to the odorants are not reaching to the olfactory cleft. The moment you remove the polyps and allow them to reach, the olfaction regains. And other is the inflammation of the olfactory mucosa itself. The adjacent inflammation of the sinonasal mucosa can extend to involve the olfactory mucosa as well. And in that case, sometimes it is irreversible. But you cannot do any sort of mucosal removal to further damage. What all we can pray is to go steroids and pray God for them to work. Give a good access for the steroids to reach to the olfactory recess. Zero. See, that is the part of the middle turbinate, stump of the middle turbinate. You can see.
Yes, we can see very clearly.
See, that is the ethmoidal skull base. All the way. Maxillary sinuses. Maxillary sinus on this side opened up. Entire ethmoidal cavity has been opened up. See the difference what it was earlier.
Yes.
That is the sphenoid sinus.
You have removed most of the middle turbinate, except the
Not completely, yes, not completely chopped. But this is a strategy, intentional strategy for allowing the steroid to penetrate to the sinus cavity. See how bad the condition is, mucosal condition.
Yes.
So in such cases, they require more extensive steroid therapy, more long-term steroid therapy. These are such recalcitrant, diseases. What is the You have to open up widest possible opening to the sinuses to allow the steroids to penetrate there. That's how you have to change your strategy. In minimal disease, you don't need that much of steroid. You don't need to widen that much.
Okay.
It's such a bad disease everywhere. See this?
Yes.
And what we are giving this way is more and more steroid through cut. More and more steroid. Okay, suction. Reaching there. That's the party wall. I'm using this through cut. Removing the septation to widen the see this? Can you see all sinuses now opened up, widened?
Yes, we can see all the sinuses.
No. And except the frontal, we have not seen yet. In this surgery, the role of surgery is to allow the steroids to penetrate. This is pure steroid dependent disease. See now the cavity.
Yes.
Now give me 70 degree. The opposite side has a lot of work to be done in the frontal. So I will do after this side. That is the main side which requires a bigger surgical exercise. See the frontal recess region.
Yes. And see the 70 degree. 120. See a lot of polypoidal disease at the frontal sinus outflow. See all this polypoidal mucosa. See the frontal deep there? Yes, exactly.
See the frontal with so much of inflammatory mucosa around. See this?
Yes, sir.
See now what I'm relying post-operative on the steroids to penetrate there. Can you see?
Yes, we can see.
And this thick beak is the obstacle. So we may have to do some sort of weak work on this side as well to increase my penetration of the steroids. Simple goal is to allow the steroids to penetrate. See, that is our frontal sinus.
Yes.
It looks so narrow it is. See that?
Yes, sir. we can
I'm
see.
afraid it can get blocked again. And this is a revision situation. Rest of the sinuses are good. You can see now. See the olfactory cleft opened up. That is the stump of the middle turbinate which is left behind. Can you see?
Yes, we can see it.
So after the frontal on the other side, we'll take another look here to see if anything more to be done to the frontal on this side. See, with this, if this sinus is, the topicals are delivered effectively, this sinus can function optimum. But this is a dicey situation whether the topicals will reach there or not. Now, coming to the more important opposite side. That has massive disease, and I'm surely going to do a draft to be there.
The participants are requesting that can you show them the anterior and posterior ethmoidal artery if possible?
I don't see right now, but yeah, in case because the mucosa has become so edematous. See this,
Yes.
the underlying small structures like arteries are not visible. Oh my God, what a disease profile in this patient. See the maxillary sinus full of polypoidal mucosa. This mucosa is bad, and I am going to take a biopsy from there to see the mucosal eosinophilia.
Okay.
One,
You do
140.
this in all cases.
Yes, 120. All cases, mucosal eosinophilia is very important. That baseline value always guides you to the therapy. And this, looking at the clinical condition, must be having severe mucosal eosinophilia. I think now with the 70-degree
We'll
in the
send it,
maxillary.
we'll send the specimen in formalin, and what you will ask the.
Yes. See the maxillary sinus, how it is completely,
Cobblestoned.
yeah. And you know, with your regular instrument, you may not reach very effectively to the anterior wall.
Yes.
See, we may not reach very effectively to the anterior wall. See, there is a lot of disease there.
Yes, we can see.
So what we'll do a different route. We will reach there. I'll tell you the sublabial route to address the interior of the maxillary sinus in detail, more aggressively,
Okay.
to reduce the inflammatory load.
Okay. You will do that in this case.
Pardon?
You will do this in this case, the sublabial route in this case.
Yes, I will push my micro debrider through that. That's a very simple, approach. See this, the sublabial route. In the mid-pupillary line. See the mid-pupillary line. Mid-pupillary line is the area where your maxillary sinus wall is thinnest.
Okay.
Just a centimeter above the gingivobuccal sulcus. See this?
Yes.
And I'm in. See, I'm in. Without any force. Let me show you. Where is our trocar cannula reached? Suction. See the trocar?
Yes, so you can see it.
Now, see what I'm using. I'm removing both trocar and cannula. And I'm introducing my red 40. Can you see this?
Yes, we can see it.
This will give us a full freedom inside. Now see. See my blade?
Yes, exactly.
Now I can somersault this. See this?
Excellent.
Full freedom. I can somersault my blade 360-degree. It
We-
can reach every nook and corner of the maxillary sinus now.
And this was a common problem we used to face in maxillary sinus.
Yeah, once you really want to work at the anterior wall. And this is one of the ideal indications, I would say. See, completely everywhere. The maxillary sinus is much better now.
Yes, exactly.
It will allow the steroid to freely flow inside. And we can remove from there. So that gives us a good opportunity to deal with the maxillary sinus more aggressively. Okay,
Yes.
0 degree. In case 10 मिनट के लिए 10 मिनट कैप मास्क में 10 मिनट के लिए हेलो
Yes, sir.
now see that was the maxillary sinus which we have worked
Yes.
back with 0 degree and such a massive eosinophilic disease again. Here is the state of the mucosa. Polyp arising from every mucosal surface, you know.
Yeah.
Now that is the ethmoidal cavity. You can imagine this is one of the worst eosinophilia situation.
And you will put this patient just on topical steroids afterwards, not on oral.
Oral for few days. You can't give oral for long. जब मैं कहूँ वापस ले आना. Because oral steroids have their own adverse effect.
Exactly. For how long you put the patient of allergic fungal sinusitis on steroids? Oral
Pardon?
allergic fungal sinusitis, if the patient is
Yeah,
suffering.
that is again a pure steroid dependent disease.
Yes.
And that's why the same thing has to be done in those. You remove the inflammatory load, that is the fungus and the eosinophilic material, and then put on few days on oral steroids and then exclusively on topicals.
Okay.
This frontal recess, we all know, is a very, very complicated one.
There is a question from the participants for how long to put these patients whether in this case or in case of allergic fungal sinusitis on topical steroids?
Long. So
Lifelong?
you have to treat the underlying cause. Like allergic fungal sinusitis, the patient is allergic to some environmental fungus.
Yes.
Unlike any allergic reaction, antigen antibody reaction, the steroid is the answer.
Okay, sir.
Now, if the offending allergen is identified and immunized, and if it works, then you may not need the steroids. Otherwise, you will need the steroids. Now, if you have now not operated, you have not given good access for the topicals to penetrate,
Okay.
you need to take oral then. So the goal of surgery to allow a good penetration of the topicals, so the need for the oral will be much less.
Okay.
See,
So
every
here-
mucosal surface, I am opening, maximum widening of the sinuses.
So here again, the reason for removing the middle turbinate, a part of middle turbinate, is to ensure the delivery of the steroids to the optical recess.
Yeah. Uninhibited delivery of steroid to the ethmoidal cavity, olfactory recess to the frontal recess, everywhere. Very simple. So bad disease it is. This particular patient has a huge eosinophilic profile. It is mucosa. What we want the steroids to apply there post-operatively. Can you see the cavity coming in shape now?
Yes, we can see.
Very simple. And frontal is most complicated, so we'll plan a proper draft for that from beginning. Widening the sphenoid wall further. See this?
Yes.
Biggest possible opening I'm trying to give.
Okay.
See now the sphenoid is much better visible now.
Yes, it's very much.
Good. I'm using the red 40 blade with keeping my cutting edges towards me.
Okay.
Otherwise, using a micro debrider and the sphenoid can be hazardous sometimes.
Yes.
See now the cavity of the sphenoid.
Yes, we can clearly see.
So we have seen the sphenoid, we have seen the maxillary, we have seen the ethmoidal cavity. See this lamina papyracea. We have trimmed the turbinate now. See this?
Yes.
So this kind of cavity can work well if the steroids are introduced post-operatively. And this is so receptive to, steroids now. Such a wide cavity.
Exactly.
हाँ जी मैंने कहा आ जाओ 10 मिनट. She has a bad disease, purely steroid dependent. See, I have removed a lot of polyps. And now this, hello.
Yes, sir.
See, now what I'm planning is a draft. The reason being, this frontal sinus, this outflow here is complicated by so many cells, and the frontal is not actually drained, not actually being, irrigated properly. Okay.
Okay.
So now what I am doing a head-on procedure, marsupialization of the frontal. That is draft.
Drop.
In draft, that is the safest region we are operating. See this mucosa. That is the beak, the anterior wall of the beak. I am removing all this mucosa. to drill the beak head on and open the maxillary sinus head on. That's a very important procedure. All sinus surgeons must know. What all you need is a good drill.
Sir, can you please explain the rationale behind this,
Rationale behind?
the DRAP procedure?
Rationale behind is a recalcitrant frontal disease with, complicated frontal recess anatomy.
Okay.
Revision case, severe eosinophilic disease, it can come back again easily.
Okay.
Bound to come back, it requires steroids. So now you have to do something to allow the steroid to penetrate more effectively. See this polyps.
Yes.
So now this procedure will allow the steroid to penetrate more effectively. See the polyps?
Yes.
Now, this area of the frontal sinus, which is not being drained so effectively, is the cells over there. See this?
Yes.
So now, what we'll do, we'll drill the frontal sinus beak. See, beak is the obstacle. See this thick bone.
Yes.
This is the obstacle. If we remove this thick bone, we'll be head on to the frontal sinus directly.
And what is the possible complication of doing this?
Nothing. See, the first thing, you have to ensure that you have to give wide opening, and as you go behind, you have to define your posterior limit. See, let me show you. See at the skull base, some nerve there.
Yes.
If I am going behind, can you see the first olfactory filament
Yes, we can see.
medially? That one white.
Yes.
That is the nerve, anterethmoidal nerve here, and that is the first olfactory filament behind.
Okay.
So in order to do that, you can drill anterior to it. You are not supposed to go behind the first olfactory filament to open up the cribriform and get a CSF leak.
Okay.
See that? That is the first level of the first olfactory filament, that medial foramen.
Yes, exactly. We can see it.
Yeah, that is the olfactory nerve, the ethmoidal nerve. So this entire bone can be drilled off, completely drilled off, to get a head-on entry into the frontal sinus.
Okay.
What's my point? That will allow my irrigation to reach thoroughly into the sinuses.
Okay.
I want my irrigation to reach thoroughly. The only thing which can prevent this patient coming to the operating table again and again is the ability of the steroid to penetrate inside. If the steroid penetrates effectively inside, the mucosa will remain healthy. See this whole bone we have exposed? And now our high-speed drill is going to work. See this?
Yes.
The limit is the outside skin everywhere. See, this is the same drill you saw yesterday, the coarse diamond.
Yes.
See, I am drilling here laterally to see the outside skin. That will be my lateral limit when you reach the outside skin.
Okay.
I hope you are oriented.
Yes.
See the level of the outside skin. Can you see the movement? Hello?
Yes, we can see.
When I press from outside, see the movement of the skin. That is the outside limit. Press on outside. Can you see?
Yes. And do we need to cover this raw surface later on, or it will heal itself?
Yeah, once you, wash with the steroid, douche with the steroid, generally you don't need. It heals.
Okay.
Otherwise, the osteitis will not allow the heal if there is too much of inflammation if you don't irrigate with the steroid.
Okay.
So you have to keep the inflammation level minimum by means of irrigating with the steroid. See the outside level? See the lateral level we have reached. Following this lateral skin level, we will move anteriorly. This is the beak now. See now we are going anteriorly to the anterior skin. Once I remove this beak is forming the floor of the sinus as well as the anterior wall. See what bone I am removing.
Yes, I just wanted to ask that we don't normally, coagulate the mucosa. So, like you said, we have to preserve the normal mucociliary clearance.
Pardon, madam, you are not audible properly. Can you bring your mic closer?
So, okay, I'm saying, like you said previously, we have to preserve the normal mucociliary clearance. But you're doing this procedure and you coagulated the normal mucosa as well. So, is there any
So
other way?
that mucosa, that is the outside mucosa, we are exteriorizing. So the cavity mucosa will grow over it. We have removed that bone, the mucosal surface and the underlying bone. What has been removed? So it will never be a problem. बैठो तुम्हारा. See this? See the bad mucosa inside. This entire bone has to go. See this still anteriorly. You have seen this lateral limit? That's the ethmoidal cavity. We have to uncover this bone. See this? We have to uncover this bone. See this? Once I remove this bone completely, your frontal will be head on in front of us. Are you oriented?
Dr. Jain, people use different techniques like Caroline flaps and other flaps and raise those before start the drilling. So what is your opinion about those flaps?
Yeah, there are many ways to do the same thing. That's the simplest version I am telling you. Don't complicate. Simple, remove this mucosa and follow this bone with the limits. My limit is this outside skin. See this? Till anteriorly everywhere I will remove the bone until I reach simply the outside skin. No complications. See, my frontal sinus is inside. Marsupializing now, opening, widening the opening. See this?
Yes.
And the entire work is being done by 0 degree only. All this bone has to go to give a wide frontal sinus opening.
Sir, can you show the skin outside?
Yeah, see this, the frontal sinus is coming in the picture more and more with 0 degree. See from inside,
Yes,
this is your outside skin.
yes.
Okay, laterally, the same skin is following anteriorly there.
Sir, the participants want to see that which part of outer skin this is from the outside of the nose.
Okay, okay. Mm, see, this is this part of the outside skin here.
Okay.
Hello? Yeah.
Yes,
So this part. So now see the more and more frontal sinus is coming up.
yes,
See the interior of the frontal now.
yes.
Lot of polypoidal disease there.
So the lamina papyracea is gone.
Lamina papyracea is here below.
Here below. Okay.
So I have to remove more. So more the bone you remove until the limits. See this?
What is the length of this bar?
Length of
This bar, the bar you are using,
15 centimeters.
15 centimeter.
This I am using at a 70,000 RPM. This is just coarse diamond.
Okay.
See, our olfactory neuron is here behind.
Yes.
Anterior to that, you can work freely. Lot of bone has to go. Lot of. See, you have to remove the entire bone to reach to the skill level everywhere to give the widest possible opening.
You will do the same procedure on the other side as well.
I may, I have kept my options open for the opposite side. See this,
Because-
this much of bad mucosal disease, see occupying the entire frontal.
Yeah.
Can you see?
Yes, we can see.
If you don't do, how can you see now?
Yes. You have approached the lateral part of the sinus as well by this route.
Yeah, I am into the full sinus cavity now.
Sir, participants are asking that where are the septas which were seen on the CT scan?
Yeah,
Think-
I have broken this one septa is yet to be, taken off. This one. This septation.
Yes.
To the smaller one I have already taken. See now, with this 0 degree, you have this sinus, frontal sinus cavity. Can you see?
Yes, we can
I
see.
will widen it more and show you. This will allow, now it's a part of nasal cavity now. See this?
Yes.
Honey. This will allow the steroid. Now this is the thick septation.
What is the angulation of the bar? Is it a straight
15 degree. It has a natural angulation of 15 degree.
15 degree? Okay.
That is really something which help us to reach out everywhere. At the same time, it doesn't come in the way. The shaft doesn't come in the way.
Sir, is this a sinus drill or the simple mastoid drill?
Yeah, this is a the skull-based drill, the stylus, used with the Medtronic console. There's a Medtronic drill.
Okay.
Now they have a newer version. We have MR8.
Can we try to do this with the help of a Carrison punch forceps or
No, no, no way. Such a thick bone cannot be. See, another cell opening up. The septation I am drilling. See the cavity, this one, another one. This is a bad signer. Why I have not said that I may or may not be doing the opposite side draft is, if I am able to remove the intersinus septum from here, and I give a drainage to the opposite side, I may not do a proper draft on the opposite side. Got my point?
yes?
Hello?
Yes, sir, we have got your point.
Let's see. Still a lot of things to go. Let me show you the initial picture at this time with the 70 degree. Okay?
Okay.
To orient you inside the sinus. Can you see the frontal now?
Yes, we can see very clearly.
See now the outside skin everywhere.
Yes.
That is the limit. Some more has to go. See, earlier the frontal was not visible even. You saw how much disease we have removed. And see, these are the cavitation because of the multiple septation.
Okay.
See the frontal?
Yes, we can see it.
Such a bad frontal it is. Graph is the ideal indication. See, all cavitation made one cavity.
Yes.
That is beauty.
Yeah. Excellent.
We'll do something more. Yes. See, now my irrigation will freely go inside.
Intersinus.
Only thing is, I need to remove this little bit of the bone more to widen it. Sorry, Lord.
अङ्कललाई भन अङ्कल गाडी गरेरमा छ
See, further widening. Another septation. This is toward the midline.
You will keep the intersinus septum intact.
Yes. Now, give me the reverse blade. See the floor.
Yes, we can clearly see.
Oh my goodness. See now the frontal is so widely open, big.
Yeah.
This is the reverse blade. to work toward the floor. See this? That was the septa I have broken to open up this cell. Now
Ye-
see,
Yeah, still there is cobblestone mucosa in the frontal sinus.
yeah, now that the steroid will take care. Once we have ensured the steroid will reach, that will take care.
Okay. Does this patient has anosmia?
Can you see the intersinus septum open? See this?
Yes, we-
Hello?
Namaste.
I am breaking the intersinus septum.
Yes.
Why not?
That will allow the opposite frontal also to drain. Whatever irrigation we do from here will drain the opposite frontal also. Drill there. Go there for 60. See the intersinus septum?
Yes.
वो drill मुकाले कर दो. Javed. See such a thick intersinus septum. See the opposite sinus.
Yes. Yes.
See the opposite sinus there.
Yes. Hmm.
This intersinus septum was so thick because of the osteitis. अच्छा पता क्यों देता है पानी
Ama, tengo campi no creo que usai desate jera ka mas.
See, I am drilling more and
Huh.
more intersinus septum.
Okay.
Staying anterior to the olfactory region. See, again my olfactory neuron is here behind. See that?
Yes.
Anterior to that, you are pretty safe. Crowd suction.
Olfactory neuron. Olfactory filament. Intersinus septum.
Yes. See the opposite sinus from here?
Yes. Yes, we can see.
Yeah. I will little bit more widen it. So that will not make me do the opposite, you know.
Is it necessary to remove the intersinus septum in this case, or you are just doing for the demonstration?
No, remove because the opposite side is also disease. That is not the sinus, you know, outflow is not that adequate. Look, see there. So I am giving additional, you know, drainage and avenue for the steroid to reach there. See, I am working in the opposite sinus now.
Yes.
See what an access.
Excellent.
See now? whatever we irrigate is going to reach the opposite side as well.
Yes.
So now I am not doing a formal draft to the opposite side. Okay.
Yes. Have you ever seen the recurrence even after such, even
Yes,
after?
yes. Frontal sinus in certain percentage of cases is so complicated. And
Okay.
ultimately, you may have to resort to the sometime to the elimination procedures.
Like,
Elimination, there are two procedures which, there are many, advanced procedures to the frontal sinus. One of them is the osteoplastic flap.
okay.
Open the sinuses from anteriorly, from above, bicoronal flap. Drill away the bone containing the mucosa, flush the entire bone and obliterate with the fat, and obliterate the frontal sinus drainage pathway, the frontal recess. Okay? Obliterate with the fat or something. Now, if you leave any mucosa behind, that can create problems. See the opposite sinus.
Yes.
In that situation, in spite of this, see now, in spite of this, this frontal sinus gets blocked. Either revise the draft or do a osteoplastic flap.
Okay.
If that doesn't work, infection takes place with the obliteration material or mucosa is trapped inside, again is a problem. In that procedure, you have to eliminate. Eliminate means behind this posterior table. That's the posterior table of the frontal sinus there.
Yes.
See, this is the posterior table. That's the anterior table.
Okay.
Behind this posterior table is the frontal lobe of the brain. So, one procedure of the frontal sinus elimination is frontal sinus cranialization. Behind is the dura.
Okay.
In that situation, even if the obliteration fails and you are planning that elimination, in that procedure, the entire posterior wall, whatever is the posterior wall is damaged, whatever, this entire posterior wall is removed. Bicoronal flap come from above, remove the entire posterior wall, obliterate the frontal recess from above, and allow this dura to expand to the anterior wall, obliterating the entire sinus, eliminating the sinus. There will be no frontal sinus to give sinusitis then.
Okay.
Allowing the dura to expand till the anterior wall by removing the bone of the posterior wall and drilling away entire frontal sinus mucosa. See now what we had the frontal sinus and now.
Yes.
Reverse. This will have a great opportunity for the steroid to reach now. Agreed or not?
100% agreed.
And see, with this kind of a profile, disease profile in this patient, if you don't do, it is going to come back. See this? Now everything is in order. I can remove this upper part of the septum as well for my better penetration of the steroid. See this? Upper
Yes.
part of the nasal septum I am removing a little bit.
Okay.
I can drill a little bit more, Lade. I want see the opposite sinus. I want the opposite sinus to be irrigated through this sinus only. See that?
Yes.
You want the steroid to penetrate inside. That's the whole goal.
Isn't this the area of olfactory? Because olfactory filament.
Not really. We are quite anterior to that.
Okay.
See, olfactory, I had shown you the beginning of the olfactory neuron. That is the first olfactory neuron. I had shown you here behind.
Yes.
Pubiform plate is behind that. So we are quite anterior to that.
Okay.
That's why you have to define the first olfactory neuron. I told you in the beginning, you have to ensure that don't enter the pubiform plate.
Yes.
So the reverse. See the opposite sinus?
Yes.
Widening more. See the thorough picture of the opposite sinus as well. See this?
Yes. We can.
That is adequate for me to reach out there. See this?
Yes.
So my drug will freely go into both the sinuses. Let me show you a panoramic view. After that, 0 degree. Wash the dhar wala. एक मिनट. See now, that is the frontal sinus with 0 degree. मेरे को ये दे, तू ये पकड़. I am with 0 degree. See the interior of the maxillary sinus.
Yes.
Remember the initial picture when we started.
Exactly.
That is the sphenoid sinus, the big sphenoid now.
Yes.
The big maxillary which will allow the penetration of the steroid.
Yes.
That is the entire skull base. The olfactory area is here behind. And this is your frontal sinus of this side. See with 0 degree.
Yes.
This is posterior table, this is anterior table, this is frontal sinus of this side, that is frontal sinus of opposite side. See that?
Yes.
That is part of the intersinus septum. This is posterior table. Now you have, if you have a case of frontal sinus CSF leak, this require from the posterior table, this require this exposure. That's the posterior table. If you have this exposure, you can then easily plug the, seal the CSF from here. What all is needed is the exposure. The sealing for the CSF is same, wherever it is coming from.
Yeah.
See what a situation. It was a complex situation. See the frontal sinus now. So that completes the surgery in this case. Let me remove the pegs from the opposite side. See this? see all the sinuses. And this frontal we have seen from opposite side as well. See from here, as I remove the upper part of the septum. Can you see?
Yes, sir.
That's the frontal there. Yes, darling. The frontal here. Yes. Olfactory, yeah. See this entire cavity?
Yes.
So we have done on both sides, and we have what I am assessing is my penetration of the steroid now. All sinuses should have free penetration of the steroid. See this?
Yes.
इधर मत जाना. Hmm? Yeah. Great. So now, any questions?
Yes, sir. First of all, there is a question from participants that, as you know, that this is not the end of the game. Now,
No, that never.
so, or we can say that this is a never-ending game. So,
Yeah. In such extensive disease,
such extensive disease. So,
because
sir,
yes,
yeah.
yes.
What will be your post-operative plan for this patient?
Yeah.
How
This
frequent-
patient, let us wait for the eosinophilic disease, and accordingly we'll plan our steroid therapy later on. Then it may be steroid resistant. In steroid resistant cases, we may have to switch to the rescue therapy of this thing, clarithromycin, and more topical steroids. Regular, very close follow-up. Very close follow-up is required in these patients. You know, they have very strong inflammatory profile. That's not a simple case. It may come back anytime. The moment you are, you know, off follow-up, it is gone.
Are you talking about the low-dose clarithromycin therapy?
Yes. Yeah, as a steroid rescue therapy, sometimes when the steroid do not respond, that's how.
Okay. And sir, for how long the therapy with low-dose clarithromycin will be given? For 1 year?
Few months, 3 to 4 months minimum, and depending upon the need, response, tolerance, it is not free of side effects in many patients taking many other systemic therapies. So never good for elderly patients. So there are a lot of things. You need to be in touch with a physician while giving clarithromycin therapy. It has a lot of drug interactions with other drugs, particularly anticoagulants and other drugs. So that's a different decision sometime. So this was a complicated situation requiring, without this draft, nobody can think of, you know, steroid reaching to the cavities inside the frontal. You saw so many closed cavities were there inside the frontal.
Yes.
Made one cavity, now steroid will flow freely into it. So
Yes.
this was the ideal indication for draft in such patients.
Okay. Okay.
Any questions?
You get a post-operative CT scan?
Hmm?
There is a question.
Post-operative, not really. Now you have your endoscope, you can see with endoscope all sinuses. There is no hidden area inside. There is no need of CT scan. Actually, for this patient, for the next की CD मंगाना.
Okay. What are the chances of getting ENS with this? Empty
What?
nose. Empty nose syndrome.
Not really.
Not really. Because
That is, I don't know what the terminology this has been given.
Yeah.
But see, as long as mucociliary activity is there, it doesn't happen.
Okay. Is there any chance of fistula formation?
Fistula for
Fistula formation,
where?
oroentral, no, because it closes very quickly.
Is fistula where? Outside?
Yes.
Satish, thank you
Sir?
very much. It is wonderful. It was a wonderful demonstration and you have done very well. I just want to discuss with you this aspirin hypersensitivity problem. You see, what we see in Pakistan is most of the patients do not give any history of aspirin hypersensitivity. And neither there is any other symptom available which will point towards aspirin hypersensitivity. But still they keep on having bad recurrence. Do you think in such situation, we should admit the patient and give them a trial to see if they are sensitive to aspirin and then desensitize?
Let me tell you various methods to diagnose aspirin sensitivity. The simplest one is a skin prick test.
Right.
Other are lots of aspirin challenge tests, aspirin nebulization test, nasal challenge test, you know, tracheobronchial challenge test. Rather than giving those to give, a spasm in the airway, a skin prick test is the simplest one. And other one, even if you don't want to do any invasive test, the best is with aspirin sensitivity, the leukotrienes are in abundance. So best test is urinary leukotrienes. Without any invasive test, if you get urinary leukotrienes high, that means aspirin sensitivity, as simple as that. There cannot be a simpler test than this to diagnose aspirin sensitivity. It cannot miss because the whole problem in aspirin sensitivity is the leukotrienes.
Right. Right.
So
Thank you.
if the patient has a urinary leukotrienes raised, that's it. That is aspirin sensitivity. Indirect, but one of the most reliable tests.
Okay. The audience is also asking, what is the protocol to desensitize a patient?
Okay, the protocol of desensitization is always in the ICU setting, number one. We start Montelukast, the aspirin, this leukotriene receptor blocker at least 7 days before to blunt the aspirin response. Because now you are giving as a therapy. You are going to give aspirin, and aspirin is going to give reaction. It can lead to severe bronchospasm, status asthmaticus, because aspirin is going to secrete leukotrienes and give problem. Patient who is sensitive to aspirin and you are going to give aspirin to him. You have to be ready to deal with any, emergency. So keep admitted in ICU. Start leukotriene receptor blocker 7 days before to reduce the leukotriene levels, to reduce the response of the aspirin. And then after admission, we start with a low dose. Low dose means 30 milligram. Oral 30 milligram, patient will immediately, present with symptoms. Nasal blockage, nasal rhinorrhea, sneezing, asthma, all these things, and you have to be ready with bronchodilators and steroids and all that. The moment it is controlled after 3 hours, raise to 60 milligram.
Yeah.
Symptoms will come, again control, raise to 90 milligram, and the tolerance ensues. That is what you look at. And then keep increasing the dose, the dose by 30 milligram until the patient starts tolerating more than 300 milligram. Sometimes we take it to 600 in 3 days' time. So once the patient starts tolerating aspirin, the game is over. Total game is over. The entire pathology will revert at the molecular level. No leukotrienes will further form and no further reaction. The whole, the game is because of leukotrienes. The moment patient starts tolerating aspirin, the leukotriene will no longer form and the entire pathology will revert. So it should be in a ICU setting with a pulmonologist setup, and the pulmonologist should be there to deal with a severe asthmatic condition which can take place after the aspirin challenge. So always start with a low dose, and that can really, you can easily tackle that reaction before increasing to a higher dose. Yes, sir. Yes.
question regarding the frontal sinus opening. What is your approach in initial cases? When you, how will you decide that this patient needs only the draft 1 or 2 or 3 procedure?
Yes,
In initial cases, that was the recurrence which we were seeing
yes.
about the
So,
initial.
yes, initial cases, if you have a diagnosed case of aspirin sensitivity, I would from beginning do a draft 3. I would do all possible largest opening of all sinuses because you need to ensure the steroid reaching everywhere. Secondly, in difficult frontal sinus situation like type 3, type 4 cells, and you have to go deep inside the sinuses to remove the cell, which is sometimes not possible without drilling it. And that may require a draft 1. In difficult frontal sinus cells, you may need a draft to go and remove all the cells effectively. In revision situation, you get to know the disease profile. If it is severely eosinophilic like this one with complicated cells, you have to take a call. Otherwise, the patient is going to come back. So primary only if it is a diagnosed case, AERD, or a difficult cellularity in the frontal sinus, not allowing you to remove all the cells effectively unless you drill the beak.
And what is your most wider or maximum opening for the maxillary sinus? Is there a centimeter sinus, or you will remove most of the medial wall in
Yeah.
aspirin patient even?
Yeah, your anterior limit is the nasolacrimal duct. Your posterior limit is the posterior wall, the pterygopalatine fossa. If you want to further enlarge, you can enlarge down to the floor of the nose. What you want is free flow penetration of steroids into the sinuses. So in massive disease, enlarge more, allow the steroids to reach effectively. You can do a good surveillance, long-term surveillance for any recurrence or anything which requires the need of steroid doses. In minimal disease, you don't need to do all that.
Satish, first of all, you did a wonderful job in the frontal sinus, and you are our virtual teacher. We learned a lot from your series of webinars in the last year.
Sure.
And my question is regarding the allergic fungal rhinosinusitis. What is your management policy in treating the younger kids?
Yes. So it mostly happens in younger generation only. Those patients having a strong immune response. Try to understand the pathology. This happens when the patient strongly reacts to the antigen. That means they have a strong immune response. Mostly happens in younger individual. Normally what happens, we are exposed to the environmental fungi. That is, fungus is ubiquitous in the environment. And we also are exposed, we also inhale, but our mucociliary activity, whatever fungus we inhale, take back to the nasopharynx and then to the gut and out. If this fungus happens to get trapped somewhere and the person is allergic to that fungus, the immediate eosinophilic reaction will trap the fungus. And that's how the irreversible phenomena or vicious cycle starts. Once it happens to get trapped in the sinuses. Mostly you'll see such patients are young, unilateral disease, and the goal is the fungus, whatever is trapped around with the eosinophilic response is there, that fungus acts as an antigen. So first you need to remove that fungus, widen the sinuses. The moment you remove the fungus and the eosinophilic reaction, your inflammatory load will come down and then follow with the steroid therapy. Steroid is the mainstay of AFRS treatment. And to switch from oral to topical, you need a sinus surgery. That will allow, or that can allow the topical to reach inside. So the surgery as a role of switch over from oral to topicals, as the topicals now will penetrate without opening the sinuses, the topicals will not enter inside. So steroid is the only answer. Then we follow these patients later on with a skin prick allergic test to the various fungal antigens. If we find then immunotherapy, sometimes it is effective, sometimes not, but the long-term steroid therapy is the answer.
Sir, what is your regime pre-operatively and post-operatively oral steroids for kids?
For this kind of disease,
AFRS.
AFRS is 1 milligram per kg. AFRS is requires high dose steroids to begin with. AFRS is all steroid dependent disease. Though it is fungal, but there is no role of antifungals. It is the reaction of the body to the fungal antigen which creates problem. It is the fungus which is not invading, giving problem.
Thank you, sir.
Satish, is there any role of these monoclonal antibodies, Zumabs, in treatment of CRS with polyps?
Yes. In selected cases, again, the role of monoclonal antibodies is to work at the molecular level to block the CRS cascade. Let me tell you, CRS is a disease which has been identified, as I told you, at a molecular level, and the entire cascade has been, identified. Now, there are targets defined at the molecular level, and for those targets, the monoclonal antibodies have developed to arrest the inflammatory process at the molecular level even before the clinical manifestation develops. So that is the future. Now the issue is the safety and long-term results, and that's how a lot of studies are undergoing. Still, these being used in various situations, in very extreme situations, in severe asthmatics, this kind of therapy is being used. Let me tell you in brief, in 2 minutes, how the monoclonal antibodies works and what is the rationale behind that. Can you connect to laptop? See now, as I told you, this is an immune complex disease. Our sinonasal epithelium is the first line immune barrier. In order to give CRS, this immune barrier has to be crossed by the environmental allergen, microorganism, whatever challenge coming to it. And see, there are 3 systems to protect or by the sinonasal immunity. One is this intact epithelium. This intact epithelium with the junctions prevent anything to penetrate into the mucosa. Second thing, anything coming onto the surface is expelled by the mucociliary system. And third is, by this cilia, a lot of antimicrobial proteins are secreted, more than 1,000 times of protein, enzyme, opsonin, so many things. So whatever environmental toxin, allergen, microorganism come to the surface are tackled by this, this immune system. These three to protect from the mucosa to breach. And once it is breached, suppose, then there are certain pattern recognition receptors are there on the mucosa. They recognize the challenge and then the adaptive immunity comes into action. So, now these are the variety of, proteins, immune molecules secreted by the mucosa to tackle lots of challenges coming to the nasal surface. Now, what happens? When the pattern recognition receptors, they sense something which is invading the mucosa, some challenge, maybe microbiota, maybe allergen, maybe protein, whatever. See, once this pattern recognition receptors are, they sense the antigen attached to the receptor, then these liposomal proteins, interleukin 25, 23, 33, they are secreted and they activate the innate lymphoid cells too, type 2 cells, which activates the T lymphocytes. And T lymphocytes are then, the response of the T lymphocyte is deviated towards the T helper 2 cells by the interleukin 4. See, these are the mediators. I am coming to why I am telling you all this. I'll come to it. That's a normal pathway. So interleukin 4 will stimulate the TS2 lymphocytes, and TS2 lymphocytes is the hallmark of the entire disease, eosinophilic disease. This will secrete interleukin 5 to stimulate the eosinophils. This will stimulate further secrete interleukin 4 and 13 to act on the bronchial muscles, to secrete interleukin 4 and 13 to stimulate the B cell, to stimulate IgE production, to stimulate the basophilic production, and all these eosinophil, basophil, they go on to the submucosal surface and give a lot of damage to the submucosa and the mucosa. This is the whole cascade which is identified now at the clinical level. Now, if this cascade, see this, if this pathway, once the pattern recognition receptors are stimulated, if this pathway of stimulating the thymic liposomal protein is blocked, let me tell you, if this pathway is blocked here, the further sequence will automatically stop. Then we have another target we have identified to block the interleukin-4 receptor. This has been identified, monoclonal antibody to block the interleukin-4 receptor. Then the interleukin-4 and 13 receptor can be blocked. Interleukin IgE receptor blockage, monoclonal antibody is available. Interleukin-5 receptor blockade antibody is available. So all these will block the further eosinophilic, IgE, basophilic response, which manifests as polyps and the ongoing CRS. So these are a lot of monoclonal antibodies developed, like anti-IgE, that is omalizumab, anti-IL-5 is mepolizumab, anti-IL-5 receptor antibody is benralizumab. It is clinically available after the, the stage 3 trials. They are being extensively used in severe asthmaticus because upper and lower airway is the same, pathophysiology. And so they are being used, but not very extensively being used in sinusitis. Yes, in extensive disease, even a single shot will reduce the inflammatory byproducts level to minimum. And it gives amazing relief, but the long-term safety is still a question mark. Long-term remission is still a, question mark. And the cost is a limiting factor as they are damn costly. So there are a lot of other monoclonal antibodies are in system, in the research work being developed at a low cost, safer and more. So in future, this is going to be the treatment to block the CRS cascade at the molecular level before the clinical manifestation develops. So this is future. Now, what can be done in the present context? In the present context, at every level, what you have seen, at every level, the only thing which works is the steroid. So now, what happens? What steroid you can give? You can't give oral steroid for longer. So what you can give, whatever disease you have, you can give the topical steroids. All steroids, short courses to give remission and then follow with the topical steroids. And if it doesn't work, that's how we give indications for sinus surgery. If the conservative management, the maximal medical management, adequate medical management fails, then the role of sinus surgery. And what is adequate medical management? Topical steroid. In pre-operative setting, what topical steroid we can give? Only nasal sprays. The douching of the Budicort and all that will not penetrate deep into the sinuses unless you have opened the sinuses. So the only weapon of topical steroid, because systemic you cannot give because of the adverse effect, is the topical. So those patients who have a very little disease profile can be managed with a topical. Those who have extensive disease profile, the topical will not work. And then comes the role of sinus surgery. I have already told you the three-pronged, target of sinus surgery to establish the ventilation drainage by removing, like we remove the inflammatory load today, and to provide access to the topical. This, in the present context, is the only weapon what we can have. Targeted therapy are underway, future, and this is going to be the future in the coming, decade or so. And if this therapy is established as a standard of care with more safer drugs, more, economically viable drugs, then the FES or sinus surgery will be less and less required. Because this is the only option right now us to do all this. It is not the final treatment. I hope you understand what I'm trying to say.
Yes, sir.
Yes, that's very good explanation. Satish, we have a problem with the topical steroids in Pakistan. This mometazine, mometazine and budesonide is available in Pakistan only as sprays. It is not available as a powder form. It is not available as drops. It is not
No, no.
available.
See, now,
Tab-
sprays and irrigations are two different things.
Yeah, because we want to give irrigations. So for irrigation, we do not have any material available here apart
No, no,
from.
you don't need. What you need to use is the budesonide respules, which are used by the physicians to nebulize for asthma.
Okay,
Those are the same respules which
they are quite expensive in Pakistan actually.
I don't think the respules are so expensive. I don't know, but those are the same thing. You ask your physician colleague
Yeah.
what respule they use for nebulization for asthma, because that is the standard therapy for asthma management.
We also want to know the dose. What is the concentration and how you prepare it for, and do you use it high volume and low pressure douches?
Yes, high pressure, high volume.
High pressure.
Tell you. Let me tell you. Yes. See, this dynamics, to understand this dynamics, these are the variables you need to understand. Delivery technique, how will you ensure it reaches everywhere? The device, then the volume, pressure, position, like we discussed the position. Then more importantly, the surgical state of the cavity. If you have not given a full house fess, like with this, in this case, you have not given a wide openings, and you have a massive profile, disease profile, your topical will not reach effectively and it is going to be a failure. So surgical state of the cavity is one of the most important determinant of the success of the topical therapy. Got my point? So we should have a good surgical state of the cavity, allowing the topical to penetrate deeply into it. And see, these are the positions I told you. A lot of devices are available. We use just simple collapsible rubber bulb. That works very well. Now, what I'm trying to say, the surgical state of the cavity. See these three cavities. This cavity, if you try to douche, see this is again a full fess done. This will not allow the steroid to reach effectively into the sinuses. Can you see the narrow cavity?
Yes.
And see on this side, the difference, the simple difference, how we achieved by just doing this high deviation correction. Can you see this high deviation?
Yes.
The moment high deviation is corrected, the cavity opened up and the whole scenario changed. Uncorrected high deviation, many a time we have seen, we have a lot of failure patient come, revision cases come. Uncorrected high deviation a simple solution, simple problem can be a reason for the overall treatment failure. So,
Uncorrect deviation of the lateral wall.
yeah, so incomplete correction of the high deviation, what I'm trying to say. This high deviation, once corrected, see the middle turbinate is pushed close to the septum and see the cavity opened up. Can you see? So, in order to make this, treatment, topical treatment effective, the state of the cavity is very, very important. And this is the solution what we use, as I told you, the budesonide nasal irrigations. Simple, 0.5 milligram per day, that too topical. Any other question?
Is there any question? Dr. Satish, I think there are no more questions. And on behalf of the organizing committee and on behalf of everyone from Pakistan who are related to ENT, I'm really grateful to you for enlightening us with an excellent surgical demonstration and opening new horizons for us in the surgical management of the nasal polyps. And we hope that we will keep on learning from you in the future as well. Thank you very much again. As said rightly by Dr. Sarfraz, that you are a virtual guru for many of us. We have learned a lot already from your YouTube videos, and we hope to see you in the future as well. Thank you very much again.
Thank you, sir. Thank you so much for your attention, for your love and affection. And I am very much attached to all of you from my heart. Thank you very much once again.
Thank you. Khuda Hafiz.
I hope कि आप सबको इस session was useful. कोई सुन ही नहीं रहा. अच्छा, अब next 10 minutes में food will be served, फिर नमाज होगी और फिर we will